Meet Steve. When he is awake, he can maintain his saturation at 100%. But when he is asleep, his saturation can fall significantly to as low as 70%. When you're asleep, your body relaxes, even your airway. In some vulnerable individuals, their airway collapses and causes a condition called obstructive sleep apnea. So, what keeps your airway open when you sleep? And why does it collapse in some patients? Welcome to the fascinating world of upper airway physiology.
The upper respiratory tract refers to the air passages that lie above the larynx and outside of the thorax. It includes the nose, the nasal cavity, the paranasal sinuses, the mouth, and the pharynx. Pharynx can be further subdivided into nasopharynx, oropharynx, and laryngopharynx. The main purpose of the upper respiratory tract is to conduct air from the atmosphere all the way to the lower respiratory tract. But that is not all. The upper respiratory tract has numerous components and they serve different functions to the upper airway. Nasal hair, for example, it filters large particles from entering the lower respiratory tract. The superior, middle, and inferior turbinates or concha serves as a conduit whereby inspired air goes through these turbinates and warm and humidifies the inspired air. The paranasal sinuses serve different functions. First, it decreases the weight of the skull. Next is serving as a crumple zone, protecting the brain from impact. They also serve as humidification, immune defense, and speech resonance. The upper airway also has olfactory receptors, so it contributes to olfaction and taste. Olfactory receptors are located in the posterior nasal cavity. The proximal location of the olfactory receptors means that potentially harmful gases can be sensed by rapid, short inspiration, such as sniffing. So any potentially harmful gases can be detected early before getting into the lungs. The pharynx is a complex organ, and its main function is conduction of air, phonation, and swallowing. The muscles of the pharynx are grouped together to facilitate its different functions. They're grouped into pharyngeal constrictors or pharyngeal dilators. The pharyngeal constrictors consist of inferior, middle, and superior constrictor muscles. These muscles contract during swallowing to propel food into the esophagus. Pharyngeal dilators, as the name suggests, it dilates when it contracts. So when they contract, it maintains the patency of the pharynx, dilating the airway, allowing airflow to occur. During normal breathing, you can see the diaphragm will contract and increases the volume of the thorax. When this happens, negative airway pressure will be created in the thorax. This will cause the upper airway to be sucked in and may collapse. The larger airways won't collapse due to the support provided by the cartilaginous support. The pharynx here, however, is unsupported, therefore they are liable to collapse during inspiration. The body then has a unique way to prevent this collapse. In the pharynx, there are three groups of muscles responsible for maintaining upper airway patency. The first important muscle responsible for maintaining airway patency is the genioglossus, which is the bulk of muscle below the tongue here. Genioglossus is the main dilated muscle of the pharynx. It causes the tongue to protrude forward and away from the pharyngeal wall. Then you have the palatal muscle. Generally, it's located inside the arch of the soft palate, like so. What it does, it controls the stiffness and position of the palate, tongue, and pharynx, as well as the shape of the uvula. Next, you have the muscles influencing the position of the hyoid. Example would be the geniohyoid. You can see this small bundle of muscles connecting with the hyoid bone. It has a phasic activity, meaning that during inspiration, it has increased activity. This causes stiffening and dilation of the upper airway. This part is particularly important in counteracting the negative pressure exerted during inspiration. Hi everyone, just a quick pause. If you enjoyed my video so far and learning something new, don't forget to click the like button and hit the subscribe button. This is Mastering Anesthesia, where we make complex things make sense one breath at a time. We have plenty of things lined up for you, and we are thrilled to be sharing with you. Don't forget to subscribe so that you won't miss out on any topics. So the question arises, what happens to the upper airway when we sleep? Remember our pharyngeal dilator muscles? Their tone will be reduced during sleep. This will lead to reduced pharyngeal diameter, and this is most significant at stage 3 of non-REM sleep. This will cause the pharyngeal wall to collapse, leading to partial or complete obstruction. Partial obstruction of the pharynx will cause turbulent airflow, and in result will cause this familiar and recognizable noise called snoring. On the other hand, complete obstruction of the pharynx will cause obstructive sleep apnea. What is OSA? OSA is a sleep disorder characterized by recurrent episodes of complete airway obstruction during deep sleep. The pharyngeal wall collapses, causing cessation of airflow. Despite this, the diaphragm still contracts, causing diaphragmatic breathing. This will cause a period of apnea lasting about 20 to 40 seconds. This will lead to hypoxia and hypercapnia. These changes will be detected by the chemoreceptors, causing it to be activated and rousing the person to be awake. Once the patient is awake, pharyngeal tone will return to normal and the patient will hyperventilate. This will continue until sleep deepens and airway obstruction recurs and the whole vicious cycle ensues. This vicious cycle of falling asleep and apnea, waking up again, this happening throughout the night is catastrophic for a person's health. It leads to sleep interruption with loss of NRM and REM sleep. These are crucial for the physical restorative properties of the sleep. The combination of sleep interruption and hypoxemia in the long run will have serious effects on the person's health. In the neuropsychiatric aspect, patient will have daytime sleepiness, poor concentration, irritability, anxiety, and depression. Endocrinological problem includes impaired glucose tolerance, dyslipidemia, increased adrenocorticotropic hormone, and cortisol levels. The vascular system is not spared. Hypertension, atrial fibrillation, myocardial infarction, and stroke is also associated with chronic OSA. What are the risk factors associated with OSA? Number 1 is anatomical factors. This include craniofacial abnormalities such as Pierre-Robin and Down syndrome, and tonsillar and adenoidal hypertrophy. Number 2 is obesity. This can be contributed by the amount of fat deposited around the neck and also the reduction of FRC in obese individuals, exacerbating the period of hypoxia. And number 3, male gender. This is probably due to the deposition of fat around the neck area. Effective treatments include lifestyle modification. This includes smoking cessation, alcohol reduction, and weight loss. Next is overnight nasal CPAP or continuous positive airway pressure. This can help splint the airway so that apneic period won't happen during the night. Now let's talk about clinical relevance of OSA in our anesthetic practice. Patients with OSA, they are at a higher risk of perioperative complications, notably airway obstruction. This can be contributed to the use of anesthetic agents, sedative, and opioids. Patients that come to us presenting for a surgery can be diagnosed or undiagnosed with OSA. Our priority is to find those undiagnosed OSA patients as they can benefit from an overnight nasal CPAP to improve their condition and optimizing them for operation. There is a very simple screening tool that we can use by the bedside to determine whether the patient has OSA or not. It is stop bang, S being loud snoring, T of tiredness, O of observed apnea, P of having pressure or hypertension, B of BMI more than 35, A of age more than 50, N is for neck with circumference more than 40 centimeters, and gender of male. So stop bang. Keep in mind that all anesthetic agents and sedatives, except for ketamine that is, reduces the central respiratory drive and reduces the pharyngeal muscle tone. Therefore, this should be avoided as much as necessary, and if possible, proceed with operation under regional or LA. However, if GA is absolutely required, some steps can be taken for the operation to be continued safely. Number one is adequate pre-oxygenation, which means patient has to be seated up to improve the functional residual capacity and applying continuous positive airway pressure. Next, the use of ETT over LMA is preferred, but remember that airway can be difficult and you might end up in a situation where it is dangerous for the patient. The use of LMA in obese individuals are prone for leakage and aspiration. And upon extubation, ensure that all muscle relaxants given has been adequately reversed and extubate the patient fully awake and in sitting position. And the use of multimodal analgesia so that the requirement for opioid and sedative will be reduced. And there you have it, ladies and gentlemen. Thank you so much for watching this video. Please don't forget to hit the subscribe button. If you like this video, hit the like button. And if any comments, any ideas, anything that you want to comment on, please comment down below. I'll see you in the next video.